Welcome back, everyone. Today, I'm very excited to share with you the updates we've made at the clinic to the functional medicine model that we are using. And hopefully, this can help you if you're looking for a provider and trying to get some insights into what, as this field of study is constantly evolving, we feel the best inclusion and exclusion of various practices, tests, treatments looks like. To lead with one stat here, 75% of people in the population, they will use complementary and alternative medicine at some point in their life. So there are many people who are looking for a non-drug approach, or maybe they've seen their conventional doctor, which is all fine and good, had a screening, and either been told there was nothing wrong with them, or again, didn't really resonate with or feel good on what is oftentimes more of a pharmaceutically dominated model. So today, here's what I would love to cover, and I'm eager to share with you, that we have extended our visit lengths, and I'll explain why that is in a moment, both for our initial exam and intake to 90 minutes and our routine follow-up visits to 45 minutes. We've cut out certain tests and focused on others instead, and this is an ongoing area of importance for certain. We've also integrated validated questionnaires, which I think have such a huge place, but don't tend to be integrated as much. And this is probably in part due to financial pressures. There's just so much incentive for labs to fund seminars and dinners and webinars and whatever. So there's much more availability of data regarding labs and much less for questionnaires, and we'll cover one in a moment, the FRDQ7, that predicts response to antifungal therapy for $0 and what takes maybe 3 minutes to fill out. We've also added, as I've discussed on the show in the past, a gut type screening. There being 3 types: bacterial, fungal, and immune. This has been so helpful to give us more direction with how to select diet and various therapies. Through some of my own pain and suffering, we have integrated more regarding vector-borne infection screenings. Now, the more antiquated way of describing this would be Lyme disease, and the Lyme bacteria, but that's not actually the most representative and correct way to label this, because other organisms that are in the sort of camp of Lyme, Borrelia, but are not actually bacteria, and this is namely Babesia, are maybe 20% more common than Borrelia. So there's an opportunity there to help people who have been floundering and haven't been able to quite put their finger on, why do I get better for a little bit and then relapse, and I can't really connect these dots. And all of this, as I mentioned a moment ago, has really enhanced our ability to select diet and most specifically antimicrobial therapy. So a lot here to unpack. Let's jump in with a few examples as to why we have extended the length of our visits. There is a SIBO, a small intestinal bacterial overgrowth example that I think is quite relevant. In some cases where there's ongoing relapsing, and people might come in labeling themselves a chronic SIBO case, which I really don't love it when anyone describes themselves as a chronic anything, but rather I look at that as this individual just hasn't found the right treatment approach yet. And that matters because the more that you sort of imbibe this mentality of being a chronic case, we know that positive expectation, placebo, and conversely, negative expectation, nocebo, will lead you in those respective directions. In any case, for some of these individuals, simply integrating probiotics for them will be the difference between floundering, relapse, regression, cycling, and more sustained improvement in how they feel. This may not be news to you if you're part of our audience, but if you're newer to our audience, and let's say you're coming from a camp of thinking that is derived from the research at Cedars, which is so wonderful in so many ways, but they're not very keen on probiotics. And so someone could, in my view, incorrectly be avoiding probiotics if they have SIBO. And again, in some cases, not all, that one integration makes a very sizable difference. And then in other of these, like in air quotes here, more challenging SIBO cases, the difference between success and failure is either a longer duration of antimicrobial therapy, different antimicrobials, or a higher dose of antimicrobial therapy. So longer duration, different therapeutics, or a higher dose are the big three. There's two other examples, knowing how privy many really now who are self-educated about gut health, and I think specifically in our audience are about SIBO in particular, that I wanted to share. And these are two examples underneath what I would term the theme, SIBO tunnel vision. So example one, we know that more people will have digestive symptoms than will have SIBO. Most namely, this comes from a 2020 meta-analysis that looked at a large group who had digestive symptoms and tested them all for SIBO. And they found about a 30 to 40% prevalence of SIBO, which is great for that 30 to 40%. But then what about the other 60 to 70% who have symptoms and don't have SIBO? This is why I think it's really important to look at, in most cases, there are exceptions to this, certainly in most of GI testing, in my view, at the lab tests as a secondary part of how we diagnose, and really making most of the diagnosis a clinical diagnosis, which weights things like your symptoms, your history, your response to various therapeutics. That's what's given the majority of the weight for decision making. And there's another point here that I also think is really important to include, which is even those without SIBO will respond to antimicrobial therapy. Most namely here, there was a 2020 clinical trial in which patients who had digestive symptoms, they were all tested for SIBO first, and then irrespective if they were SIBO positive or SIBO negative, they were all given the antibiotic rifaximin. And guess what? A large subset of those without SIBO improved. So depending on the sort of philosophy on SIBO you've been reading or viewing, you might hear different things. I think there's a fair cohort in the SIBO community who say, use the test as a screening, but you can still treat someone for SIBO or with antimicrobial therapy like rifaximin or herbals if their SIBO test is negative. Now, it's also possible that there is something going on in the gut that won't respond to antibacterial therapy. So consider this example. Someone comes in and they're, again, labeling themselves as a chronic SIBO case, a challenging case. So we do some digging in the longer visits now into their prior lab work. And we see that SIBO that's been, at least purportedly, the reason for all of the symptoms and strife and struggling was only barely positive. So maybe it was a rise of 25 in the hydrogen or a value of 15 for the methane. So what I would consider a very mild positive. Well, that may not mean that the symptoms are coming from that lab finding then. Okay, we dig a little bit more. There was minimal or no response when this person had used rifaximin previously. So another data point skewing us away from thinking that SIBO is the main driver of symptoms. But also perhaps they had a better response from antimicrobial therapy. Now hang on a hook for 1 second, we're going to come back to it. We keep listening to and trying to uncover everything we can about this individual, and a few other things come up. History of recurring vaginal yeast infections and or toenail fungus, and or a repeat use of antibiotics, maybe as a child for acne, or there was recurring ear infections, just to use two examples. Perhaps also they're eating low FODMAP, but we see, boy, this person sure is eating a lot of starches because they've read that people with SIBO can eat starch because the starch doesn't feed the bacteria. But when we take this all together collectively, it starts painting a picture that fungal overgrowth or candida might be the culprit. Remembering that starches will feed fungus and that the herbal antimicrobials, many, I would argue almost all of them, are both antibacterial and antifungal. So there can be a very important breadcrumb trail of clues in someone's history if you're really looking for the most important pieces to pick out. One of the things that we've also discussed many times on the podcast in the past is hypothyroidism and how problematic the indiscriminate use of thyroid hormone or loose diagnoses for hypothyroidism are. So there's another example here where someone, as again, we're digging into their history, because so much of the direction is set out of the gate. Good inputs equal good outputs. So the better the quality of our inputs, understanding the person, the better our outputs, our recommendations are going to be. So someone may say, well, it's this thyroid issue. I really got to get to the bottom of this thyroid issue. So again, we dig in and we look at the labs that made the diagnosis, and they weren't actually diagnosing hypothyroid. They were diagnosing subclinical hypothyroidism, or what's known as sluggish thyroid. So we paired that along with, there's no family history. So this is painting a certain picture. When inquiring further, they commented that when they went on Levo, or maybe they went on a desiccated hormone of some sort like NP thyroid, they didn't really feel any better. And we pair that with one other really important breadcrumb, if you will. They have irregular cycles, they have hot flashing, they have heavy bleeding, and they have PMS. So it could be that what happened was the subclinical hypothyroidism wasn't driving the problems. It was a red herring, so to speak. And the female hormone imbalance symptoms, having so much symptomatic overlap with hypothyroidism, were missed. And as a couple of data points here, we've discussed the Journal of the American Medical Association meta-analysis that looked at, well, maybe people with sluggish thyroid, if we give them hormone, will improve. And it's been fairly clearly demonstrated from this meta-analysis of 21 different clinical trials where researchers attempted to test this hypothesis that no, people who are sluggish thyroid do not see either thyroid-related symptom relief or quality of life improvement when they take thyroid hormone. And we pair that with this other landmark meta-analysis from the journal Thyroid that found 37.2% of people appear to have been misdiagnosed. Why? Because they could discontinue their thyroid hormone, maintain normal thyroid levels all on their own, and see no change in their symptoms. That's huge. That's 1 in 3 individuals. And by the way, if this has been helpful, please comment and subscribe. I really do appreciate hearing what people think, so I'll look forward to reviewing your comments. Okay, so moving along to the piece about the tests that we're focusing on and some of the questionnaires. As you probably know, many functional medicine tests, functional medicine being a newer field, are theoretical, and we don't really have sufficient data to know, are they helpful, are they not helpful? So what ends up happening there is it becomes incumbent on the clinician to start testing these tests, so to speak, to start looking at, well, do these tests seem to correlate with how people feel? Meaning when people are really ill, do we see a moderate to severe level of positivity? Or maybe people who are healthy are paradoxically showing terrible lab results. We're no longer using any sort of quantification of the microbiome like a U-biome as an example. And we've discussed in the past how they were shut down for insurance billing fraud, but then it also came out that U-biome was using in part dog and infant feces to establish their normal ranges. We're not using neurotransmitter testing labs. We're not using adrenal testing labs. And this enters a wonderful study regarding adrenals from Quigley that found when successfully treating the gut, cortisol output corrects itself. So if someone does have a gut imbalance, which maybe 40% of the US population has what's known as an FGD, a functional gastrointestinal disorder, it's a broader categorization than IBS. IBS, as great as that is, it's a little bit limited. It doesn't include things like reflux. If 40% of people have digestive issues, then maybe 40% of people who are complaining of adrenal symptoms or have aberrancies on their adrenal labs have the key to resolving that in their gut. We also spent some time evaluating a new stool test. And yeah, I find this, quite frankly, to be ridiculous. So we've performed about 10 of these tests. Open-minded, it came recommended from a colleague that I trust. So, okay, let's give this a test and see, because I'm going to take the first step of inquisition based upon a colleague's recommendation, but I'm not going to do it on blind faith. I'm going to want to assess this test seems to be accurate. And of the 9 or 10 tests we've done, I think every single person came back positive with cryptosporidium, which is ridiculous. I mean, we're not talking about testing just in one small cluster of people who are often drinking well water or river water. I mean, it's no way that you would see a 90 to 100% positivity rate for crypto. And Giardia was also somewhere just estimating around 70% positive in this population. So what we were able to discover, sadly, was yet one more stool test seems to really suffer, in this case, from false positives. Bear this in mind. For people, and I've actually been in this camp, who had a false positive, meaning the test says you have the thing, but you actually don't, they end up undergoing, in some cases, months of treatment until the clinician says, something here isn't adding up. Let's modify our approach. So a clinician who has adequately screened the tests that they are going to recommend is worth their weight in gold, in my opinion, knowing, again, that functional medicine being new, we just don't have enough validation data to confidently conclude these tests are accurate or not. So the clinician really has to screen, have their thinking cap on, and continually be weeding out tests that are not accurate or beneficial. And one more test that we're no longer doing is the urinary mold testing. And it was quite interesting to compare notes with Tanya Dempsey, who's been on the podcast in the past. She's a Lyme and MCAS specialist. And she's essentially gathered the same suspicion that we have. And we have as one of a few ideas of papers to publish, pooling our data and publishing a case series so that other doctors can read through this and maybe have a little bit more pause before they go down that road, as we did with a number of patients looking at this. Oh, okay, if we can help someone, let's do it. But let's do it with our eyes open. And numerous people came back on the other side of detox and binding therapy and just no response or very little response, and then almost zero correlation between how they felt and their lab values. It's possible that we're missing something there. There are some people who make compelling cases for the use of these tests, most namely Neil Nathan, but after about a year and a half with this under the microscope, so to speak, just can't say I'm seeing any signal of benefit. Now, there are tests that we are using and focusing on. Hashimoto's, a screening with TPO, is going to be the most accurate, and or with ultrasound. The thyroglobulin, or the TG antibodies, upon a pretty deep dive into the research, you do not see a correlation between disease, dysfunction, thyroid hormone production, and thyroid gland health and thyroglobulin antibody levels. In fact, one study was very, very telling in the sense that tracking people and looking at their levels of TPO compared to ultrasound and their levels of thyroglobulin compared to ultrasound, what you found was low levels of TPO, normal ultrasound, meaning the thyroid gland tissue is healthy, high TPO, and you had scarring of the thyroid gland. But guess what? With thyroglobulin antibodies, there was no correlation. So this is important because thyroglobulins, antibodies, that is, they do suffer from false positivity and cross-reactivity. So that has helped us better attune the screening for Hashimoto's. And then, like I alluded to before, being a bit more scrupulous with how we look at their TSH and their free T4 to be able to tell people or just help direct them to, this is suggestive of hypothyroidism, action needs to be taken. This is subclinical hypothyroid. The majority will revert back to normal over time with no intervention. So we can wait and see and monitor and use nutritional therapies to help increase the health of your thyroid gland, like we've discussed before, vitamin D, selenium, myo-inositol, and also red light therapy. And make sure that people don't start lifelong thyroid hormone medication if they're sluggish thyroid, because like we discussed before, those experiments have been run and the jury's in, and those individuals are not helped from the medication. One of the or a few of the questionnaires, I should say, that we're using help to quantify a bacterial type gut, a fungal type gut, and an immune type gut. So some testing updates, and now the questionnaires specifically. There's a form known as the FRDQ7, the Fungus Related Disease Questionnaire, and there's 7 questions. This questionnaire has been shown to predict if someone will benefit from antifungal therapy. So hugely helpful in the sense that we now have a predictive measure, and stool testing, maybe. I think it's a little hit or miss. You can do blood antibodies, and antibodies can be helpful, but they're really an indirect measure of diagnosis. So they do have shortcomings. And then a urinary dearabinitol can also be helpful. Now, if you want to do a robust candida screening from an objective lab perspective, people have to do a stool test, a urine test, and a blood test. And some people, especially if they're not feeling well, they just don't want to jump through all the hoops. Now, the scientist in me wants that data on everyone, but the clinician in me needs to keep things practical. And so that option and the recommendations are there for those who want to do them, and that is data that we do track. But what a gift for the people who don't have the time or the resources to do the testing. We now have a way of predicting. We've been developing, and we're hoping to, in the future, publish and validate a questionnaire that we've entitled the FRST27, the Fungal Symptom Tracker 7, or the Fungus Related Symptom Tracker 27, excuse me. And what this is doing is it's taking the symptoms that we would expect to change over time and putting that into a separate questionnaire. What I mean by that is the FRDQ7 is a baseline risk screening tool, meaning you won't see a change in someone's score on have you used antibiotics in the past, have you used birth control in the past. Those are both risk factors from the FRDQ7, but those aren't going to change over time. And I'll show you in a moment. Let me show you now. This is part of what people will see with their fungus-related symptom tracker. This is actually a best case scenario. So what you're seeing here is 2 slope lines. The first is a drop, again, best case, quite precipitous drop in their fungal-related symptoms over time as they started doing antifungal treatment. And we're marrying that with a quality of life measure, also validated, known as a PROMIS 10. And this is a beautiful textbook example, but what you're seeing is, and probably not surprising, but as fungal-related symptoms go down, quality of life goes up. And so these are the things that we're really excited to be sharing with patients and kind of giving people almost a stand-in for the lab test that's at least partially research validated and will help us track these things over time successfully and really be able to better understand how these symptoms respond to treatment over time. And then also, this is a nice view to have of your progress over time. So I did want to loop in a data point because the gut typing model, remember those being bacterial, fungal, and immune. This isn't purely theory. One study by Satish Rao has been on the podcast in the past. He's a gastroenterologist at U Augusta. He screened a group of people who had digestive symptoms with no known cause. Look at this. 25% had SIBO. 21% had candida, and 21% had SIBO and candida. So this helps us, I think, better understand that there's a bifurcation in terms of what's going on in the gut causing symptoms. Now, the challenge with the candida diagnosis here is technically Rao was looking for small intestinal fungal overgrowth, I believe from a direct sampling, which is not something that's due to invasiveness available for routine clinical practice. Hence, why the FRDQ7 and FRST27, I think, have so much utility, because it's a stand-in for what is not routinely able to be tested via labs. A different study, again, looking at people with unexplained gastrointestinal symptoms, found that 23% of these individuals had histamine intolerance. So hopefully that helps you to see why we're trying to really identify and take direction from, are they bacterial? Are they fungal? Are they immune types? Some will actually be both bacterial and fungal, but my suspicion is that one of those is going to be the more important lever to pull on therapeutically to improve someone's health. We'll see. I might change my mind on that with time, but that's how I'm thinking about this, at least at current. The other questionnaire that I think has just a massive amount of utility is a questionnaire screening tool known as the MSIDS 38, developed by Richard Horowitz, who is a Lyme specialist and researcher. 38 questions that have been shown to correlate with if someone has a vector-borne infection, and also correlate with successful treatment over time. One of the reasons why I think this is so helpful is it's a bit pricey to screen effectively for these vector-borne infections or microbes. Again, this is Lyme, Borrelia, but also more commonly Babesia, and secondary to that, Bartonella. I'll come to a few more details on this in a moment, but a good assay on this, looking at a combination of what's known as direct and indirect measures. So something like a FISH test that will actually stain the RNA so you can see the actual microbe, paired with some sort of antibody test. You're looking at about $3,000. We are experimenting with a panel that's $1,300 that I think will do a pretty good job of doing an initial screening. There's also a at-home finger prick blood test that only costs $450, but the challenge is it's only looking at antibodies, and antibodies by themselves are only giving you an indirect measure. So the level of confidence, the specificity, and the sensitivity are going to be lower. So these are things that we're experimenting with. But coming back to my earlier comment about a clinical diagnosis, this is where we look at, well, where do you live? Where did you grow up? Is this a Lyme endemic area? And then an MSIDS questionnaire could then give us more of a rationale for doing follow-up testing. But let me share this. So this comes from a patient I was working with only a few weeks ago. She came in complaining of headaches, leg and spinal pain, brain fog, blurry vision. Digestively, there was bloating, gas pains, and constipation, spider veins or broken blood vessels. This is a very important sort of presentation to cue in on. She came back positive for 2 species of Bartonella, Elizabethae and Henselae. Now, Bartonella, it's known to show up in an individual who has predominantly neurological symptoms. So looking at this individual, headaches, spinal pain, brain fog, blurry vision, right? There's a predominance of neurological symptoms. Here's the quick checklist of some of the keynote symptoms of Bartonella. Again, if there's a predominance of neurological symptoms, insomnia, brain fog, mood disorders, paresthesias, tingling and numbness, joint pain, muscle pain, which can include shin pain as a very characteristic finding, or tooth or gum pain. Also, skin lesions. These are known as Bartonella-associated skin lesions, and there's a few sort of subtypes, if you will. Bacillary angiomatosis, which are these small, raised, pimple-like, reddish lesions that people will often confuse for acne. Petechia, which are broken blood vessels under the skin. So there's little bruising spots, not a big bruise like you bumped your thigh onto the coffee table, but small little circular like bruises. Stretch marks, spider veins. And because Bartonella likes to reside in the endothelium, the lining of the blood vessels, you will see things like uveitis, red eyes, or even eye pain. And there may even be a connection with connective tissue damage leading to a hyper flexibility syndrome like Ehlers-Danlos. Now, I mentioned before that the most common of these organisms is Babesia. So there's a few symptoms here I want to make you aware of so you can do a quick self audit. Constant fatigue, a feeling of air hunger or a shortness of breath, like I just need a big breath. I kind of can't catch my breath. I mean, sure, if you're exercising, that's different, but I'm talking about if you're barely exerting yourself and just feeling this shortness of breath or this air hunger, feeling tippy or off balance, having a cough of no known cause. You're not sick. You just have this dry, unproductive cough. Hot flashes. This is a big one. Hot flashes, especially waking up hot. Now, we want to put on our thinking caps here in the sense that if this is happening with someone who's going into the menopausal transition, or it's only happening when someone's premenstrual, then these hot flashes are probably hormonally mediated. But if you're not seeing that clear correlation to menopause or PMS, then this is a major flag that Babesia could be present. Also, panic attacks that last longer than an hour, and thank you to Dr. Bransfield over at iLads for making me aware of this, and dysautonomia, like a racing heart or POTS syndrome, essentially hypo, low blood pressure. All of this, everything that we've discussed filters down to being more precise with the diets that we select. Right? The bacterial types will want low FODMAP. The fungal types will want a Candida diet. The immune types will need a low histamine diet. And sometimes it's a combo, but this at least gives us some initial direction. And then maybe most importantly, understanding what antimicrobials to use and how someone may respond to antimicrobial therapy. What I mean by that specifically, a few things. That those who have a vector-borne infection, Babesia, Bartonella, Borrelia, or have Candida, these two seem to be the most likely to experience a die-off. Why that is so important is because some people will misconstrue a die-off reaction for, oh, well, I don't tolerate that. I tried it and I had joint pain. I tried it and I had a headache. I tried it and I didn't sleep well. Now, sometimes that will happen. This is part of what the clinician needs to disentangle. But just being able to prep someone before they go into antimicrobial therapy, hey, your FRDQ7 was positive or was high risk. We're going to start into antimicrobial therapy now. Just a heads up, you may notice that your symptoms get worse before they get better. 2, 3, 4, 5, maybe 6 days where you may notice joint pain, abdominal discomfort, brain fog, headache, fatigue, malaise, or even some new symptoms that only last a number of days. But it's important that you don't incorrectly conclude, oh, I didn't tolerate that herb or whatever it was. And I've shared in the past this table that we've been painstakingly developing, which lists a number of antimicrobials. And with this view, we can look at a herb or something like monolaurin and say, okay, this will hit SIBO, but it won't hit Candida, or this will hit Candida, plus it will hit Babesia. But not only that, this will hit the active Candida, it will hit the Candida biofilm, it will hit the Candidal hyphae, or a filament that sort of makes it more resistant to treatment. So this can help if we're looking at someone who's more of a chronic case, or where we have a suspicion of more than one organism present. We can skew and have a slightly more precise selection of antimicrobials. As you'll also see from this table, many of the herbals will hit multiple organisms, so it's never going to be a total targeting of only one organism, but this at least helps us to be a bit more precise in how we use antimicrobial therapy, which for some people is really the difference between success and failure. A few other things kind of as we come to a close here. Of course, we're always looking at someone's exercise. That's crucially important. Their sleep hygiene, their stress, and within stress, helping people have a non-pathological or non-fear-based perspective around food, For some people, especially the type A individuals, can give you a 20% bump in how someone's feeling in a matter of a week or two. Pelvic floor dysfunction for people who have this constipation that is more of a incomplete evacuation or partial straining can be very helpful. As you would expect, we're continually refining our use of the elemental diet, probiotics, immunoglobulins, female hormone supports. As I mentioned earlier, for some people, the red herring was something like sluggish thyroid, and the actual issue is their, let's say, their gut, their diet, and some herbal female hormone support. Hyperbaric oxygen therapy. The really nice thing about this, so this is where you go into a chamber, a pressurized chamber that ranges anywhere from 1.3 up to usually about 2.4 atmospheres of pressure, which is about 10 to 40 feet underwater. That's the equivalent, while breathing in 100% O2. And especially for the people who've had the vector-borne microbes, if you look at the pathophysiology of these bacteria and protozoa, Babesia, Borrelia, Bartonella, it's almost a perfect correlation to the mechanisms of healing for hyperbaric. Mitochondrial damage, mitochondrial repair. Vascular damage, vascular repair. Immune dysfunction and suppression, immune enhancement. Reduce circulation, especially to the brain, improve circulation to the brain. Potentially a accelerated aging effect, and then a stimulation of stem cells. So one of the roadblocks here has been not all people have a hyperbaric clinic near them. And then in some cases, it's an issue of cost. We have been experimenting with this wonderful company, at least my conclusion thus far, that will literally ship you an at-home hyperbaric chamber so that if we're undergoing antimicrobial therapy and we're not getting quite the kick that we'd like, we see these synergizing together very, very nicely in some cases. And I'm actually currently undergoing a round of treatment myself. And kind of coming back to my theme from a moment ago, I've done 2 rounds with an at-home unit in the past. And both times, when I got to about 3 weeks in, I had some of the best energy and cognition I've ever had. But I also started having racing heart and insomnia. Now I better understand that this was almost for certain a die-off reaction. And if I had pushed through after probably about a week of that reactivity, there would have been even more improvement on the other side. So hence my comment earlier that understanding or having a suspicion of what organisms are at play, which ones are more likely to cause die-off, and giving people the preface about that so that they can stay the course, again, and not make the mistake that I made, can be very helpful to make sure people are really getting the most out of their therapeutics and not getting a few steps in, pulling back, trying something else, a few steps in, pulling back, and so on. Hopefully this helps and gives you some things to think about, to speak with your local healthcare team about, or if you need, you can always reach out to the clinic, and provides what I think is sort of a newer model of functional medicine, things to include, things to not include. Again, I hope this helps, and until next time.